Good morning. My name is Ellen Mitchell, and on behalf of Ernesto and myself, I'd like to welcome you to the TB Stigma Measurement Symposium. This is the culmination of a lot of work and thoughts and meetings that we've had over the past year. There was a TB Stigma Measurement meeting held in The Hague in May that brought about 50 people together to think both about the quantitative but also the qualitative measurement of TB stigma. And as a consequence, there have been a series of systematic literature reviews that were commissioned, and the start of what I think is a pretty dynamic and also fun network of TB stigma researchers. Now, from that little group, I also see some TB stigma experts in the audience who are not yet members of that group. And so we are an expanding, open, interesting community. And your presence here suggests to me that that we're sort of a bigger group than previously appreciated. I think most of you realize that the NTB strategy has as one of its three pillars this concept of ending suffering.
Goals.
Yeah, goals, thank you. The operationalizing that suffering, I think Ernesto's been rather eloquent on this matter, that it, so far, it's only been operationalized as, in terms of cost. I think being in this room, you realize that cost is important, but insufficient to capture suffering, and the need to measure reliably and in valid ways different types of TB stigma. It remains a pressing scientific issue for us, but also a pressing sort of political or advocacy issue. So we are very fortunate to have with us this morning some of the foremost innovators in terms of methods for measurement. And so without going on and on, I'd just like to introduce our first speaker, Dr. Aaron Kipp, a research assistant professor in the Division of Epidemiology at Vanderbilt. He is also a member of the Vanderbilt Institute for Global Health. And welcome, Aaron.
Hey. Well, thank you. It's good to be here. Good to start off this symposium. I have no conflicts of interest. I don't have a whole lot of time to go into all the work that's been done around stigma, so I just want to present briefly some definitions and some simple frameworks that will lay out some things that I'll mention going on. So this is definitely an overview. You'll probably hear bits and pieces of this from other presenters. It's difficult to start any talk about stigma without referring to Goffman's seminal work in the 1960s, where he defined stigma as an undesirable or discrediting attribute that an individual possesses, thus reducing that individual's status in the eyes of society. There has been a lot of formative work, health psychology, since then. There are lots more definitions, but these are two that have been particularly helpful for me. So Lincoln Phelan defines stigma as a process that involves labeling, stereotyping, separation, status loss, and discrimination occurring together in the context of a power differential. Context there is very important. Process is important. Similarly, another definition specifically states it as a social process related to personal experience, characterized by exclusion, rejection, blame, devaluation, that results from experience or a reasonable anticipation of an adverse social judgment. I think that's an important addition to some of these definitions. So how do you take a process like that and formalize it? I'll present here a couple frameworks from the HIV stigma literature that I'm familiar with. There are many others. There are more complicated ones. There are ones from mental health. These have been helpful to me. First and foremost, thinking about, are we talking about an infected or an uninfected person? So in this example, if we take an HIV uninfected or a TB uninfected person, we might think about stigma in terms of prejudice, stereotypes, and discrimination. In contrast, somebody who is infected with HIV or with TB, we might talk about enacted stigma, anticipated stigma, internalized stigma. So enacted stigma being experiences of discrimination, anticipated, what I worry might happen to me because of my status. And internalized stigma, it's when the individual owns all the negative attitudes. I am to blame. This is shameful. It is my fault. So they own that on themselves, is what we refer to as internalized stigma. What's missing from this are some other terms you'll hear: structural stigma, so institutions, things that are outside the individual that might drive a stigma, as well as courtesy stigma, which sometimes referred to those who don't have the condition, but in their role with those individuals feel the stigma themselves, maybe a caregiver, maybe a health provider. That particular framework has been expanded with the addition of perceived stigma, so we start to get into some nuance here, but again, this is just an individual sense of what's normal, what are the normal attitudes around this condition in the community. I like this particular figure here because it represents that these are related. Enacted stigma, experiences of stigma might inform your anticipation of future stigma. And then it further lays out that under anticipated stigma, there are different sources of the stigma. It might be friends, it might be family, it might be health workers. Vicarious stigma is a variation on some of these you may have heard of. So there have been prior reviews on stigma, measurement of stigma. I've listed a few here. There was a quite comprehensive review on HIV stigma scales. I identified 23. I can tell you from my work that I could pull out over 30 different HIV stigma scales if you wanted. These others reviewed multiple conditions, but each only reported on one TB stigma scale. So the objective of this review was to identify published TB stigma measures and evaluate them and think about the way forward using them. We did a comprehensive search of the literature through about July 2016. We also looked in some known publications, some gray literature, and we began to review references from our selected studies to see if, perchance, we'd missed anything. This is what we looked for, basically tuberculosis and everything else. Various forms of words that get back at some of those processes. We reviewed the title and abstract of everything that was returned. We were looking for studies that specifically report on the development of a scale, but I also wanted to include those that used a scale, just to see what is being used, what are the properties of those. Began to look at studies on TB knowledge, attitudes, and practice, although those became very complicated because attitudes is very broad. Any study looked at predictors of various outcomes, and stigma did not have to be specifically mentioned. So again, if we found a quantitative measure of prejudice, that falls within the scope of what we were looking for. We reviewed these, the papers that were selected from this, and ultimately what we were looking for, because this is a measurement review, is a set of items, I'll come back to that, that represent one or more of the domains I mentioned previously: prejudice, enacted stigma, internalized stigma. In which case, these are summed to give you a score. That's the quantitative value that we work with. So if a paper reported on that, we included it in our review. Let me just briefly talk about some of the criteria used to evaluate some of this. Here is a good introductory book by Bob DeVellis on scale development. Basically says that a well-developed scale should have these components: content validity, construct validity, reliability, and he adds replication. Some may or may not agree with that. There are certainly ways, variations on this. I've tried to keep it simple, helps me keep it straight. Content validity refers to the extent to which a set of items adequately reflects a construct. Stigma is a construct. It is unobservable. It's something that happens, and we try to tap into that. And the way we do that is with a set of items. This comes back to the importance of having multiple questions to measure stigma. A single question, do you feel stigmatized, actually is not adequate to capture all the emotions and the processes. So we look for sets of items that collectively tap into stigma. So that's what we mean by, is there content validity? And those can come about through literature review, qualitative work, expert opinion, that sort of thing. Construct validity is the extent to which our measured variable, so in this case our score, behaves the way we expect it to behave. And there's some statistical techniques, factor analysis being one of them that's important. Correlations, how does my stigma score correlate with depression scores, self-esteem scores? So things that we would expect to be impacted by stigma but aren't themselves what we would call a measure of stigma. Reliability refers to the items that we've selected, how intercorrelated are they? That's done primarily through using a Cronbach alpha. And then finally, replication. I think it's really important, I'll present some of this, that certain measures be shown to work and to be used over time and in different contexts. If we can continue to use this and say that it's working, that is in of itself a piece of information that says this is a good scale. So moving on to our results, you can see those. We identified a mere 8,400 abstracts to charge our way through. You'd be surprised when you put TB and discriminate into a search, you get a lot of laboratory studies. So we weeded through those. I also learned that in the dental literature, TB refers to a toothbrush. And there's a physics term that I don't recall that is also TB. So we excluded for a number of reasons. This was not a qualitative review. We were not interested specifically in HIV stigma, so we excluded a number. We ended up with nearly 400 papers to begin looking at, and it's not a firm number because we're still plowing through some of these. We looked at the full text to see, do they report on a multi-item quantitative measure of a stigma or stigma component? And a number of these, there was not evidence of that. Some were still trying to find the full text. Some actually turned out to be literature reviews. Some still were just qualitative. And then we get into this gray area where some measured stigma by asking, like I said, a single item, do you feel stigmatized? Or a set of attitudes that I'm not really sure if this is stigma or not, so we excluded those. And what we've ended with to date are 24 studies that report on the development or validation of a stigma scale. I'm going to present those. An additional 17 that seem to report a stigma measure, but there's still some unclear details there. And so I'm seeking some information from the authors, and we'll revisit that. And then a large number that I've yet to go through, so this number could certainly grow. So if you developed a scale and you are here in the audience and I don't present your scale up here, it's possibly in that middle 17 and I need to talk with you, or I haven't come across it yet. But either way, come talk to me afterwards because I want to make sure we get everybody in here. So what did we find of these 24 studies that we reviewed? Across the globe, primarily though in the Americas, as well as Southeast Asia. I found 14 what I call unique scales, meaning that they were entirely different. Some of these scales were reused in a different group. So a scale that was developed for TB patients was then adapted and used in community members. I'd still refer to that as a single scale. So there were 14 of these. 9 of them were among TB patients, including one that sought to address stigma around latent tuberculosis as well as stigma around suspect patients. 5 in the general population, including one focusing specifically on family members. 3 measuring stigma among healthcare workers, and 1 that actually measures some structural stigma. Many of these developed their own scale from the ground up. However, 2 of them used an HIV stigma scale and essentially switched out words and applied it to tuberculosis. Others adapted mental health stigma scales that existed, or a chronic illness scale. I've tried to use pictures because I tend to use a lot of words and I'm boring, so I'm trying to make this visual appealing. So I have my red, yellow, and green here. This goes back to those validation criteria. This is purely qualitative in the sense that this is my rating that I came up with, and hopefully it conveys a general idea of what is there. We could get into all the details if we wanted, but this is just sort of a broad stroke. So in terms of content validity, if a scale involved qualitative methods to develop the set of items, that's good. If it used an existing TB stigma scale, I said that's good. If it adapted a non-TB stigma scale, okay, not bad. We'll give that a yellow light. Obviously, if nothing is reported, then red light. The construct validity, as I alluded to earlier, can be assessed primarily through a factor analysis and doing correlations with related constructs. So if both of those were reported, again, green, very good. If one or the other was reported, okay, we're partway there. If none of them reported, then there just really isn't information on that. I've shown that in red. And then with the reliability, I just looked at the Cronbach alpha. It's the most popular statistic used, and 0.7 is a general cutoff. So above 0.7, good demonstration of reliability. Below that, yellow, if nothing reported, red. So what I have here is my color graph. And again, we're just going to just take it in. We're not going to talk through each individual measure here. There's not time. But these are the early years of papers that report having at least a few of these criteria met. What can you see here? Well, let's take this very first one that I have listed from Westaway. It actually used some prior work around related TB stigma, so I gave it a yellow for the content validity. It did do a factor analysis, but not a Cronbach alpha, so it's a yellow for the construct validity, or excuse me, but not a correlation, and it did not report a Cronbach alpha, so red for the reliability. In contrast, you have the MAC 2006, which was very well developed, prior mental health scale with some qualitative work, so it's green for content validity. Construct validity, I believe they either did a factor analysis or looked at some correlations, and then it had very good reliability with the Cronbach alpha. So that's what we're getting at with these colors. And as you can see here, two things. I presented multiple domains of stigma in my frameworks early on. All of these were single domains, so a set of items that sort of combined together a little bit about prejudice, a little bit about discrimination, a little bit about internalized stigma. This bottom one here, the Woith and Larson, begins to introduce multiple domains, and that's because they adapted an HIV stigma scale, which specifically had those 4 different domains. If we keep moving on to some more recent publications from the TB patient stigma literature, we actually see some good ones here. This SOMA article used a method called explanatory model interview catalog, which I'm not super familiar with, but is a very good mechanism. And it was adapted here to look at latent tuberculosis. So again, that's essentially the same measure, but adapted for a slightly different patient group. And as you can see here, these ones fared pretty well in my rating schedule. And we're also starting to see a little bit of splitting stigma out to multiple domains. So those were the 9 TB patient scales. When we look at the 5 general population stigma scales, it's actually a really different picture. These are pretty well developed, employing a lot of the methods that are needed for a valid study. And again, these aren't all brand new scales. This was, again, an adaptation of the explanatory model interview catalog, and then one that was developed for TB patients in Thailand that I also administered in community members in Thailand. But across the board, good properties of these scales. There were 3 healthcare worker scales, again, adapting an existing scale, and some recent work by a colleague of ours from the meeting, a quite good healthcare worker scale out of South Africa. And finally, I stumbled on something I'd never seen before, at least in this literature, which was a measure of TB stigma in TB health literature. So it doesn't quite fall under the domains of those that I presented earlier. There really isn't a way to do content validation of that, so I don't really know what to put there, but quite novel. I understand that it's used in other disciplines, but I had not run across it. So I'm flying through these. Hopefully the pictures have been helpful. The final component is replication. And really there were just 2 scales that have been picked up and used by others in different contexts. The first one, as I mentioned, was initially, the TB items were initially published by SOMA in 2008. It utilizes this explanatory model interview catalog, which was developed for really any condition. The original study by SOMA et al. Was done in 4 countries, Bangladesh, India, Malawi, Colombia. It was adapted in the US and Haiti contexts, and then has been picked up and used by others more recently. And these generally have demonstrated good properties when they relooked at the content, relooked at the construct validation. The second one is the Van Ries scale. Full disclosure, my dissertation advisor, which was developed in Thailand for TB patients. I adapted that slightly, and we administered it in the general population. And that scale has been picked up and was shown to work very well in TB patients in Mexico. I was pleased to attend a short oral abstract of the cultural adaptation of our scale in Brazil, which performed very well, and ran across a poster here yesterday that also used our scale, but as far as I could tell, did not do any validation work on it. These are really the two that I could identify. Granted, I still have some more to look through, but of the 14 unique scales that I identified, these are the two that have been picked up and used by other investigators in other countries. Does that necessarily mean that they're better? I don't know. It, to me, demonstrates that there's reason to reuse them. They can be used in different contexts. Something that goes from Thailand to Mexico to Brazil, hopefully is tapping into some salient themes across contexts. I figured I need to spend more time putting my slides together, so I decided to graph out where are these publications, when have these publications been coming out, and what you can see is following a short outburst of publication activity in mid-2000s, there's really been a lot of, there's been sort of a resurgent here in the recent years, as well as some revalidation. So these hash bars are the studies that took an existing scale and applied it in a new context. These gray ones are some of the ones that I'm still yet to, they either had minimal detail or didn't cover all of the validation criteria. But stepping back, there seems to be a surge of interest in this. I was sitting in the waiting room this morning after turning my presentation and heard Stephen Lewis talk about TB stigma being more of a problem maybe than HIV stigma in just a little interview that he gave that was recorded. So there's interest, it's coming out, there's a lot of work to be done. So here's the takeaway slide. There are already a lot of TB stigma scales, and given my work in the HIV context, I would caution against coming up with more. If some exist, I suggest we use them, find ways to adapt them. That makes it easier to compare information across contexts. Unfortunately, there is a lack of specificity of the domains. I think we need scales that tap into specifically internalized TB stigma. There's evidence that a specific domain may affect particular outcomes, and so we need that level of specificity. The development and validation has primarily occurred in the Americas and Southeast Asia, although there has been some recent work in Africa. I mentioned the two scales by Van Ree and Soma that seem to not only be well developed, but also to be replicated and reused elsewhere. The MAX study was also well developed, but for whatever reason has not been picked up and used in other contexts. Two takeaways from this are these last 2 points here. I think we need more clarity and more validation of healthcare worker stigma. Are healthcare workers stigmatizers? Are they the recipients of stigma because of their work with TB patients? Some of these, two of the scales actually presented a patient vignette and was asking the healthcare worker about what do you think the patient experienced. So there's still a lot of ways to look at the healthcare worker stigma. I think we need to clarify that. And finally, there's a lot of interest in LTBI and multi-drug resistant. Do we need to look at adapting some things to assess stigma around these types of tuberculosis? There hasn't been a lot of work, so is there room to do some of that? So two of my takeaways from this review. So I'd like to thank Ellen for her work in sort of spearheading all this, and certainly all the colleagues from our meeting in May. Some of you are here, a lot of good discussion. My graduate student who's been instrumental in moving through a lot of this literature, and USAID and Challenge TB for their support of this project as well. So thank you very much.
Thank you very much, Aaron, for this. We all get excited about working in stigma. We see that, we experience that in different ways, but then when we try to see how to do something, then the measurement is critical. And then after a presentation like this and a summary like this, you might be a bit scared about moving forward. However, there are opportunities to look at how we can come out with measurement that can be generalizable and that can be more easy to implement and consistently across different settings. So we are very much pleased to have Dr. Charlotte Colvin. We are going to have questions towards the end of the four presentations. Dr. Colvin is working with USAID as a manager in evaluation and has had a long interest in stigma over the years, which has increased actually recently. Thank you. Floor is yours.
Thanks. Oh, it did magically appear. I was You sure you don't need to press the button? So thank you very much, Ernesto. Thank you to all of you for being here. And thank you so much, Erin. That was such a great setup. And my presentation is going to take a somewhat different drill down into some of the themes that Erin talked about, but that was a very nice way to introduce the topic. And thank you very much to Ellen, too. Much of the analysis that you're going to see here and some of the metaphors we're going to talk about are actually Ellen's work, and I was only able to undertake this with a lot of support from her. So what I'm going to talk about is the specific issue of disclosure and whether or not by measuring willingness to disclose a TB diagnosis, we can get a handle on things like internalized stigma, anticipated stigma, whether or not it could serve as a proxy for anticipated TB stigma in the general population. And the background for this is that, as Ernesto mentioned, I work for USAID, and as part of our new U.S. government TB strategy for 2016 to 2019, we've really tried to put a new emphasis and reiterate the importance of patient-centered care and the quality of care and the human rights of TB patients. And specifically, we're very interested in stigma and the effect that stigma has on the patients themselves, on healthcare workers, on families. And we really need some quick and dirty measurements because we have to, what gets measured is what gets done. And we do have an indicator in our overall M&E framework for the strategy around measuring stigma in different populations and different stakeholders related to TB. And we thought that disclosure might be a convenient measure for looking at whether or not stigma exists and getting a handle on the level of stigma in a population. We know that DHS data have been used to explore disclosure of a variety of health statuses, including HIV, but also we have a lot of experience with the DHS for reporting not only stigmatized, but particularly sensitive health matters, miscarriage, infant death, things like that. And so we know that we know a lot about how to ask about disclosure. And the question of whether or not disclosure could be a proxy for TB stigma is linked to our understanding of the disclosure of HIV status. So this is to say that our thoughts on whether or not this would be a good proxy is sort of inspired by what we know about disclosure of HIV status. And frankly, we had the desire and an opportunity with our new strategy to explore this further. So just touching for a minute on this inspiration of TB, of HIV disclosure as the use of the HIV status disclosure as an inspiration for TB. We thought that we need to acknowledge that there are very different decisions around disclosure for HIV and TB. They're related but not the same, and that primarily has to do with the nature of the illnesses. So, with HIV, you're talking about a chronic illness versus an episodic. So there might be perceived differences in the temporality of stigma. Casual versus non-casual transmission. A lot of stigma is rooted in fear, and with HIV, we know that many of those fears are unfounded, and we can actually intervene on that. We can correct perceptions about whether or not it can be transmitted casually. We're in a very different territory with HIV because it is airborne. So if someone reports a stigmatizing attitude that's rooted in fear, it's a little more difficult to deal with because there is some risk that you could become infected in a more casual setting than with HIV. And also, and this is a little bit questionable, but the idea of whether or not a diagnosis is concealable. It may be in many ways more easier to conceal an HIV diagnosis, whereas depending on the programmatic context of TB, of the TB patient, it's more difficult to conceal. For example, if you're wearing a mask or, and I know in the United States, when I was working in TB, we had to go to great lengths to disguise DOT visits in order to avoid a patient being stigmatized or sort of being outed as a TB patient because they were receiving a visit from a health worker. So this is just to acknowledge that, that they're not exactly the same, but they might be related. So what I'm going to spend the rest of this short presentation on is our efforts to try and understand disclosure in the context of San Pedro Sula, Honduras. And in the interest of full disclosure, this is vintage data. This study was undertaken for my dissertation research. San Pedro Sula is a very large urban center in Honduras. It's the epicenter of HIV in Central America. And originally, this was a study of delays in healthcare seeking behavior for TB symptoms. So the study population was a random sample of just over 500 patients who had been screened for TB symptoms at all of the TB dot centers in urban San Pedro Sula and had been found to be symptom positive and were then waiting to provide sputum for a test. So they were not confirmed TB patients. And the dependent variable was a measurement of delay, and stigma was an independent variable thought to predict delay. And so we were looking at whether or not perceived stigma was associated with delays in visiting a clinic for TB symptoms. But this gave us the opportunity to also explore, because we were asking questions about disclosure, I'll talk about that in a minute, as a proxy for stigma, we had an opportunity to explore that as the dependent variable and look at what factors might be associated with whether or not a person was willing to disclose. And it gave us an opportunity to do some more in-depth analysis on the scale that was used to measure stigma. So the scale that I was working on, and again, the reason I mentioned that it was vintage is that it was actually long before some of the scales that Aaron presented, although I would have used them if I had had access to them at the time. This is sort of the domains that we were trying to measure. And the idea is that by measuring these things, could we measure stigma? So, and I'll go into what the specific items were on the next slide, but if we measure negative stereotypes about people with TB, measuring social distancing of people with TB, measuring discrimination against people with TB when their diagnosis is disclosed, comorbidity linking the association with HIV, and then the perceived need for secrecy. So it was a 9-item scale, and these were sort of the domains that it was measuring. And our question was, if we measure all of these well and we measure them in a scale, are we actually measuring stigma? Ooh. So the next 2 slides just cover the specific items in these domains. So the first 3 are trying to capture the stereotypes, the negative stereotypes of people with stigma, and these are very specific to the Honduran context. So people with TB are usually poor, they live in an unclean house. In the context, that is a particularly insulting thing to say about a person, so the negative stereotype. And a person with TB has very little education. Then on the social distancing, and I apologize, these are out of order, but if a friend of mine had TB, people would avoid him or her. We also asked a more direct question. If I knew a friend of mine had TB, I would stop being friends with him or her. We recognize that many people would not probably be willing to admit that in a scale, so we sort of asked the proxy about it, about if my friend had TB, would other people avoid him or her? And then for discrimination, we were looking at what we thought to be a pretty direct measure. If a friend of mine has TB, she or he would probably lose their job. On the comorbidity, if a friend of mine was diagnosed with TB, I would also worry that that he or she had HIV/AIDS, looking at whether or not there's an assumption that someone with TB always has HIV. And this was particularly interesting to look at in the Latin American context, where co-infection rates are much lower, but in San Pedro Sula actually much higher, and probably the highest in Honduras and probably the highest in Central America. And then finally, we sort of got at disclosure from a positive and a negative point of view. So on the positive side, we asked if people agreed with the statement that it's better not to hide that you have TB because you could benefit from the support of your friends and family. So this would be sort of measuring the inverse of stigma. We want to you should disclose because people aren't going to judge you, they're going to support you, and they're going to provide help for you. And then on the negative side, the more extreme, you should only tell others when you're really, really sick and you have no other choice. Because if you tell them any earlier, the idea behind this was you'll be rejected and there'll be enacted stigma towards you. Oops, so just going quickly to the summary results, the stigma scale was overall relatively reliable with a Cronbach's alpha of 0.7. We need to do some further analysis on this and go further, but we think it has good psychometric properties, and relieved to see that it's relatively reliable. When we look item by item, we discover that the disclosure items don't really contribute very much to the scale, but at the same time, they don't detract from it. They don't compromise it very much, which leads us to conclude that it may not be an actual proxy for measuring stigma, but we know that there's an association. And I think that Ellen came up with a rather brilliant metaphor, particularly for the clinicians in the room, that maybe measuring willingness to disclose is somewhat like using an IGRA test. So when you test somebody with an IGRA, you're not measuring the disease itself, you're measuring the reaction to the disease. And in here, we're thinking about stigma as a consequence of, we're thinking of whether or not somebody is willing to disclose as a consequence of stigma. So whereas a smear or a gene expert might tell us whether or not the bacteria is actually there, we can't say that with this, but we know that there's an association, so maybe it's kind of like performing an IGRA. And we also know that there were higher mean stigma scores among those who prefer to hide their TB diagnosis. So we know there's something going on there. So yes, no, or maybe. We still have some work to do on this. Like I said, based on the summary results that I just presented, we know that this could be useful, but we don't exactly know how. We have to have practical considerations and feasibility. Putting on my hat as someone representing a donor, yes, this may be useful, but ultimately we also need to be collecting some information that would help us figure out how to intervene on stigma. So this might tell us a little bit about whether or not those interventions are working, but we also need to find ways to collect some data that tells us about the origins of stigma in a particular population and lends us very useful information on how we could intervene on it. And then there's also the feasibility question. We are very lucky in that there's some parallel, we have the opportunity to try some of these questions out in the context of catastrophic cost surveys. We're talking to our colleagues at WHO about ensuring that their ongoing research and pilots to measure catastrophic costs among TB patients could also include these questions, because why do two separate surveys when you could do one? But we also need to think about, realistically, if we're trying to understand this as what would be some other opportunities for us to measure it that would be feasible and practical. And we also believe that further analysis of both this and other data sets, for example, the DHS, and I know that Miriam's going to talk a lot about that, and will provide a good overview on that, will also contribute to our understanding of stigma and the measurement of stigma and help us inform this ongoing discussion about scales. So that's actually all I have. I would like to take the unorthodox opportunities to ask my colleague Ellen if she would like to add any last thoughts to this, since we have a couple, I think I'm not completely over time yet. And I also just wanted to thank all of you for being here, thank my colleagues at USAID for providing me the opportunity to work on this, and obviously all the many TB patients or people with presumed TB many years ago who agreed to answer the questions in this study. Ellen, do you want to say a word or two?
I just want to make one point, which is,
Mike.
yeah. So Charlotte has shown that disclosure questions can be a surrogate marker for TB stigma, but are not TB stigma. But disclosure questions are also associated with some other things which I think are interesting, and we didn't present this, but one thing to think about, they're also associated, people who aren't interested in disclosing their disease in this study were also more likely to travel farther and pay more to get care. So this is a group of people who are concerned about privacy so much that they don't actually seek care in their own communities, but are going farther. So that might not be stigma mathematically, but we're really interested in that group. So the disclosure questions, the HIV community has tossed them out. I don't think we're ready for that. That's all.
Thanks, Ellen.
Ellen.
Okay. Thank you. So you introduce meeting?
So now we get to hear from Dr. Miriam Bucker. Dr. Bucker is a senior epidemiologist at KIT in Amsterdam. She leads a great team of epidemiologists. And a lot of Miriam's work is around building capacity. In addition to being a TB stigma measurement expert, she's also a GIS expert and has been, she won't present it today, but she has some gorgeous stigma maps you should ask her about later.
Thank you, Ellen, and good morning, everybody. Like Ellen said, my name is Miriam Bakker, and I'm presenting here on the team who worked on this, the analysis that I'm going to present, which includes Ente Rood and Christina Morgan-Taylor, Masha Stratemans. Ente Rood and Christina did most of the analysis under the guidance of Alan Mitchell. Let me continue. Let's see how this works. Okay. The question is, and it really nicely follows now from Charlotte's presentation, is that we were, like she said, this disclosure question, if a member of your family got tuberculosis, would you want it to remain a secret or not, is being used in nationwide demographic and health surveys, the DHS surveys. And this analysis is really to explore the utility of this question. Is it useful to analyze this data? Has it been widely used? What does it tell us? Does it increase our knowledge on TB-associated stigma, courtesy stigma? And I thought it would even be nice maybe for you to think one moment, would you keep TB a family secret? Because the question is a lot about who are those people, because that's what we're going to look at. Who are those who want to be kept a family secret? So maybe you can think also a moment, would I want to keep it a secret? Like I said, so we're looking at this question. Maybe I should repeat it one more time. If a member of your family got tuberculosis, would you want it to remain a secret or not? The answers that we look at is yes or no. There was also a category of don't know, not sure, depends, combined. And for the sake of this analysis, we don't include that subgroup, just to be clear on that. The key questions that I'm addressing is, okay, what is the variability of, I call it TB stigma, although we just heard it is a measure of, it is associated with TB stigma, but what is the variability of it among countries and within countries? Can we say something about it? What are the individual epidemiological correlates of TB stigma? Who are those people that want to keep it a family secret? Are there individual associations or maybe epidemiological nationwide variables that influence it? And then we go one step further. What is the relation between disclosure, non-disclosure, and health-seeking behavior? So that's the final slide. I hope I'll make it in time to also present that last bit of slides, because that's the next step. If you can use it, then also to look at health-seeking behavior. A little bit of background. Don't want to look at it, go into detail too much, but what we look at is courtesy stigma. It's a kind of an indicator, a measure for courtesy stigma, which, like Aaron already indicated, can be defined as a carryover stigma experienced due to linkage with a possible stigmatized person. So what we look is at the non-disclosure of TB in a family, assuming that is, or that's what Charlotte already showed, is associated with a courtesy stigma, and then maybe associated with anticipated stigma. I'm going to present quite an in-depth, quantitative and analytical study that we did analysis. And this slide is just to show to you that we didn't do some kind of fishing expedition, because, like I said, we are using DHS studies, those demographic health surveys studied in the general population, and they measure hundreds of variables. So we could, of course, look for any association with this outcome measure, the non-disclosure, but we didn't. We really thought, okay, what are possible factors that are associated, that link with courtesy stigma, to really limit to those variables and not do some kind of fishing expedition and look for any associations. So we really focused on some social characteristics, some national epidemiological context specific variables, so a few or one structural driver, and then some knowledge factors. And anyway, these were the whole list of possible factors driving the courtesy stigma, from which I definitely should mention HIV accepting attitude as a social characteristic that we took into account. We looked at age, wealth, some of these. Then we had several national epidemiological context variables that we took into account. We had a range, but since these are the nationwide variables, and we only limited in the end to 5. I will show you later on a slide. Anyway, yeah, just again to show you, we used a framework behind the selection of variables. So what did we do? We had 15 demographic health surveys selected from priority countries. These were collected between 2005 and 2014, and these had the non-disclosure question questioned and some other TB-related questions in there. There were 4 from Asia, 1 from Europe, 8 African, 13 countries in total. There were 2 countries where they had a repeat DHS survey done. So in the end, we collated the individual records, and we ended up with a database of over 500,000 individuals, which is quite cumbersome to work with. And and these were individuals from the general population aged between 15 to 49 years old. So in the end, we had selected 8 individual covariates to explain TB non-disclosure, which was age in categories, sex, education, also in 4 categories, if I remember well, religion, wealth. We used the standard wealth index, which is a standard measure that DHS provides you based on, it's a composite measure based on, I think, 4 different types of questions. HIV acceptance, also a measure that DHS provides, also based on a set of 4 questions. Then there was a knowledge on TB transmission, a question on knowledge of TB transmission, and a question on knowledge on TB curability that we included. And in the end, from a set of national covariates, we selected in the end 5. There was a lot of collinearity between different national covariates. So we selected 5 that represented a few teams, which in the end is TB incidence. And we included the incidence of the year of study, the year of the survey performed. And I just this week, I took the last estimates, so from the 2016 report, but then of course not then the historical estimate of the year of the survey. We took HIV prevalence. That one was less precise. It were the 2012 estimates for all surveys. We looked at alcohol abuse in the countries, prison population rate, and knowledge of TB transmission also. So there's knowledge of TB transmission is as the individual who knows about TB transmission, and there is a variable included that tells how does the population, does the population know about TB transmission. And then we did multi-level logistic regression using the survey design, univariate and multivariate analysis. So first, just let us have a look on where are the countries that we included. So you see the 8 countries across Africa. Across Africa, so there's Nigeria, there's Namibia, Zambia, Malawi, Zimbabwe, there's Tanzania, Kenya, and Ethiopia. Ethiopia twice. There's Ukraine as the European country. There's Tajikistan and Kyrgyzstan, or the Republic. There's India and Cambodia. And you see, we've grouped them here in 3 groups to see a little bit of how the variation across the globe. Of course, you also clearly see there are any countries from the Americas included. So it's just focusing on Africa, India, and just only Ukraine from Europe. Ukraine had the highest percentage of non-disclosure. And the lowest was in Cambodia, if I remember well. Anyway, this one is to show where are the countries that we studied, but also the huge variability between countries. And that's also shown in this graph, maybe a bit more clear, where you see the different surveys with their percentage of non-disclosure. Overall, it was almost 26% of general population that said, I want it to be kept a secret. You see this high variability again between surveys, varying from 15% in Cambodia to 71% in Ukraine. Also, Zimbabwe shows a very high percentage. Then let us look at India. Maybe I should also mention, I haven't done it yet, but India was the largest survey, and out of those those 500,000 individuals, 1 out of 6 came from India. So it is a really big representation of the results, which of course is also worldwide, because worldwide probably it's also 1 out of 6 that come from India. Oh, sorry, that was the map of India. Just to, what I was just presenting were the national estimates. Of course, doesn't mean that it's the same throughout the whole country. And just for one example, we used to look at how does it vary within a country. And this is India, using this survey from 2005-2006, where it was 16% overall, quite low. But ranging from 3% in the lowest regions to 41% in the highest. So again, you see this high variability between regions, which of course, if you would go into a state, because a state is again a huge area, you would see again a lot of variation. Okay, so let's talk a little bit about the covariates that we put into the model. Like I said, we use knowledge on curability. I thought it may be also interesting to show then how many people knew that tuberculosis is cured, because that was the question, can tuberculosis be cured, yes or no, which varied from 75% in Nigeria to 93% in Namibia. There was some variation in Namibia between the two surveys, I must say. I also indicated India, like I said, as this is the largest survey. Knowledge on transmission, how does tuberculosis spread from one person to another? It was an open question, but the answer categories are fixed. The correct answer, through the air when coughing or sneezing, was provided by 53% in Tanzania, up to 95% in Ukraine. But on the other hand, if you look at the HIV accepting attitudes, which is, like I said, based on a set of 4 questions, only 1% in Ukraine has a HIV accepting attitude. Maybe also says something about the measurement of the HIV accepting attitudes. I won't go into detail there, but we use the same standard set of questions. 39% in Namibia had a HIV accepting attitude. So varies a lot. So now I'm presenting the results of those individual covariates. I'm presenting the multivariate model, where also the national covariates are included. So what we did, because we had those 8 individual and 5 national covariates, we just added them into one model to see the results. So that was the multivariate model, including all the variables in there. And these are the results of the individual covariates. We didn't find a difference between males and females, so they had the same rate of disclosing. Also, education levels were not seen to be related. And knowledge on transmission in the multivariate analysis wasn't significant anymore. In univariate it was. I will go a little bit into that later. We saw more secrecy among the younger age and the higher wealth quintiles. And then what you also see in the graph, we saw less TB secrecy among those who were, had an HIV accepting attitude. And that was really the strongest relation with secrecy. Like I said, the knowledge question was not significant anymore in the multivariate analysis, but the knowledge on TB curability still was significant. The more those who knew it was curable were less often wanted it to keep a secret. Yeah, which was quite interesting, I think. So then let's go a little bit more into detail about, I'm not sure how I'm with time, but let's go a little bit more into detail about those knowledge questions, because it was quite interesting. Because in univariate, we saw that the more people knew about transmission, the less likely they were to disclose, the more likely they were to keep it a secret. But when you look, but in multivariate, we didn't see that as strong as anymore. But when you look at the individual countries, we also saw it really goes both ways. In some countries, you see indeed what we saw in the univariate, that like in Ukraine, the more you know about transmission, the more you want it to be kept a secret. The same in Zimbabwe. But like in Tanzania and Namibia, you don't see it. Then there are also a lot of countries where it's not significant, and that's also probably, right, and then especially India, the biggest one. I don't know if you can, where is my pointer? India, there's no difference at all, which is the biggest survey. So I think this really also shows there are really other underlying factors influencing this relationship. The same for curability. In curability, it remains significant. So the more you know, so if you know it's curable, you are less likely to keep it a secret. You don't want, which is also well, maybe explainable. And we saw that indeed in many countries, but again, there are a few countries where it's the other way around. So it's not consistent across countries. And I think that's the main message here. We do find a relationship overall, globally, but there are individual country differences. The picture, which I'm not showing, which I just received yesterday evening, was the same picture for HIV accepting attitudes. For example, the one that I showed had a very strong relation, and we saw that in all countries. So that was really consistent across the board. So that was, I was quite pleased to hear that. Now let's look at the national covariates. So we looked at TB incidence, HIV prevalence, alcohol abuse, prison population rate, and knowledge on TB transmission in the population. And I just realized I'm showing the odds ratios, but what I should have shown is the strength of the association. These are all continuous variables. So what you see here, for example, with HIV prevalence, it's in percentages. So what you see, if the HIV prevalence would go up with 1%, non-disclosure risk would go up with an odds ratio of 1.11. But like if you look at the prison population, looks very strong here. With an, well, looks very strong. Odds ratios are not that big, but it looks as if it's the strongest relation, the strongest association. But in fact, what you see here, it's if it's one prisoner more per 1,000, then indeed it increases. But that's quite a high number, 1 per 1,000, and it would probably be better to look at it one step per 1 per 10,000, and then I just looked at it. The odds ratio reduces, of course, a lot, because these are continuous variables. So it's much better to look at the strength of the association. And when you look at the strength of the association, HIV prevalence had the strongest association with non-disclosure. So that was the most important one, followed still by the prison population and TB transmission. In here, it shows as a very small relation, but in fact, it had a similar association as alcohol and prison. These were in the same order of strength. It all has to do, because here, if you increase the knowledge by 1% in the population, which of course is nothing, of course your odds ratios increase only very little. So the conclusion is secrecy increases with higher HIV prevalence, with a more prison population in country, more alcohol abuse, and it decreases with a higher TB incidence. That's the results. Just like for my last 2 minutes, we quickly also looked at the association between disclosure and health-seeking behavior. So in this analysis, health-seeking behavior is the dependent variable. So we looked at mothers with children under 5 with a cough, and then see whether they brought them to care or not. And we looked at 6 individual covariates, including TB secrecy and HIV acceptance, age, education, religion, and wealth. So the data sets reduced to about 26,000 mothers with a child under 5, still a huge sample size. And then we looked at who brought their child to care, and did that depend on whether or not they wanted to keep TB secrecy. And what we saw is that it was not really dependent on TB non-disclosure, but very much dependent on the HIV accepting attitude. So those mothers who were having an HIV accepting attitude more often brought their child with a cough to care. So that was quite an interesting finding. So not so much related. There was a tiny relationship with TB non-disclosure. It was significant, but of course with a sample size, a population of 26,000, you find significant relations quite often, quite easily. So we did find a relation, but we really don't see it as an important one. But we did see, and I think that's just nice to show that the analysis was quite well, I think, because we really show this nice increase in health-seeking behavior with increasing wealth and also with increasing education. You saw a really nice relationship with health-seeking behavior. Now, then I think I just have my discussion slides because my time is done. I think just to mention, of course, pooling data from 15 countries into one database really comes also with the risk of overgeneralization, and that's why we also try to look a bit more into the individuals between countries. And of course, those 15 surveys are not representative for the whole world. And I think I should probably mention that we felt that it really brought some interesting findings using this data, although with the limitation that it's not actually measuring TB stigma, but it's a proxy for it, or it's an association with. We still find it increased the knowledge. But I think that's also up for the audience to decide, and for those who want to learn more, like, is this now a useful analysis or not? And then these are my conclusions, which I think is more repetition. We saw the variability. We saw really an important association with HIV accepting attitude. I think I should leave it with this.
Thank you very much for this great presentation. We move now to our last speaker of the symposium. I mean, if the picture is not complex enough, let's look at what happens when you factor multidrug resistance and HIV. Our colleague Amrita Daftari is an assistant professor at the University of McGill, has been working now for more than 10 years, giving the perspective using qualitative methods into HIV and TB epidemic in collaboration with University of KwaZulu-Natal in South Africa, looking at HIV, TB, and DRTB. Floor is yours.
Thank you. Yellow car came to my house and asked the surname. She came out and put the gloves on, and it was clear that this is bad. When she came inside the house, everything was special and urgent. My child said, "We learned about this at school. It's better when it's MDR. When it's X, it's the last stage. That is when you're about to die. I am so sick of this vehicle because people know about it. They're standing on the road, putting these things on and writing names on the bottles. They don't even come in the house. They ask while they're outside. My son just ran away. He doesn't want to sleep here. It's because they told me about XDR in his presence." So how are we going to capture this in a series of 10 questions? I challenge the audience. So thank you very much, Ellen, for having me here and for including qualitative methods and the importance of qualitative research in our efforts to assess and measure stigma. I'm going to talk about 3 things today. First is
How might qualitative methods inform our understanding of stigma in TB? How might HIV and drug-resistant TB introduce chaos into some of our assumptions about TB stigma? And finally, what are the implications of these ideas in our efforts to measure stigma? It's not all going to be a downer, I promise. So this is sort of the subtext of my talk. Much of what I'm about to say is based on the experiences that I've had working with CAPRISA in KwaZulu-Natal in South Africa, which has been dubbed Ground Zero for the TB-HIV epidemic. And in KwaZulu-Natal, it's really the root problem of MDR-TB that drives rates of TB and HIV co-infection. Nearly 70% of TB patients in this area are co-infected with HIV. So that's the context within which I bring some of these points. South Africa also has a very rich social and political history. Economic inequality is pervasive, and rates of TB and HIV are both substantially higher in people of lower socioeconomic status. And often these disparities run along existing lines of race, gender, and age as well. People are also very charged to action. There's been a tremendous amount of advocacy in South Africa, especially in the field of TB, in the field of HIV. And nonetheless, however, tremendous deficiencies exist in the ways in which HIV and TB and drug-resistant TB are managed in the healthcare system, how they're discussed in the media, and how they're brought to light in policy making. I'd like to foreground the lens with which I come to this problem of stigma and make sense of how we understand and respond to it. I use qualitative methods, and I think this brings us to the first point, is how can qualitative methods assist us in sort of understanding what TB stigma is all about? Because to me, stigma can be seen in multiple ways and multiple realities, and all of these realities are valid and coexist at the same time. So in this room, if all of us were affected with some sort of a stigmatizing attribute or condition, how we experience it and how we understand it can be quite different, right? You might feel very offended if somebody looks at you funnily because of what disease or illness or social attribute that you have. I might only feel offended if you don't sit next to me, but I'm okay if you give me a bad look. But the intensity of my hurt and my pain might be equal to yours, even though we've experienced very different things. And so that sort of subjectivity and context of stigma is something that I think is really crucial to understanding what stigma is. As Aaron mentioned, stigma is also sort of quite varied in its manifestation and the forms in which it occurs. And numerous other authors have written about this. I mean, there's the stigma that we might perceive or feel, but not necessarily see or experience. There's the stigma that might get enacted through an overt act of prejudice or discrimination. And then there's the stigma that we might feel and experience, but somehow have managed to resist or deflect or ignore, leaving us essentially without the sense of stigma. And all of this might, of course, change depending on our place, our time, our social context, where we are with our disease, how the public and media represent it. And this sort of leads us to the idea that stigma is socially produced. It's not just something that happens and is felt by an individual. And so the data source, in my understanding of where stigma arises, is not necessarily the patient or the person. And Aaron kind of alluded to this, right? And when I talk about stigma being socially produced, I worry less about whether it's perceived or enacted. Whatever it is that we hold to be stigmatizing is sort of dependent on potentially 5 successive steps that have been postulated by Lincoln Phelan, and numerous other authors have sort of taken this up, and they're all rooted in Goffman's theory that was mentioned earlier. So first is, of course, this relative difference that needs to occur, this labeling that needs to occur between what's normal and acceptable in order for stigma to start to be produced. And then there's a form of othering that needs to occur as a result of those who are stigmatized are separated from those who are not stigmatized. And then there's a process that can lead to overt acts of discrimination or devaluation or internalized stigma, like the outcomes of stigma. And the final point is really, really crucial, the exercise of power. Right? We talked a little bit about healthcare workers feeling stigmatized, but by whom? So if a patient complains and doesn't want to sit next to a healthcare worker, the healthcare worker is very unlikely to feel stigmatized. But if his or her colleague or a senior member of his or her community decides not to sit next to him because he's working in an MDR-TB clinic, then he might feel stigmatized. So it depends on who and where the stigma is coming from. because patients are at sort of the lowest hierarchy of that social scale. And they're much more likely to feel powerless and more stigmatized as a result of what happens to them. So all of this leads us to question, do we know what we're measuring? Right? Stigma is not necessarily standardized. It's not this bounded, limited, singular thing. And so we just need to think about, when we measure stigma, are we accounting for all the other important pieces of an individual's history or life, or his community, or his social context in sort of understanding how he experiences or feels stigma? The second question is, are we measuring TB stigma or something else? Right? I think we can all agree that TB is a social disease, and perhaps not always, but it often overlaps with numerous social inequalities. And people with TB might be dealing with these multiple overlapping issues. Things like HIV, their immigration status, their gender, all of which might be associated with their own negative identities, stereotypes, and stigmas of their own right. And so people may or may not compartmentalize these various stigmatizing things within them when you ask them particular questions on a scale. So we just have to think about whether it's possible to separate the stigma associated with TB from the stigmas associated with their other social realities. And a related point is, do we want to separate it? Because what's the ultimate goal of measuring stigma? Do we want to reduce TB stigma, or do we want to reduce stigma affecting patients with TB? So I'm going to talk about some of the diverse dimensions of TB stigma in relation to its co-occurrence with HIV and in relation to drug-resistant TB. And over the next few minutes, I'm going to introduce you to a few quotes that have been shared to me by men and women who've lived with HIV, with TB, and with drug-resistant TB in South Africa, because I think their narratives reflect the experience of TB and the stigma of TB far more eloquently than I ever could, and what it means to feel, to understand, to ignore, to resist, and live with stigma. So traditionally, TB has been seen as a disease of the poor, the wasted individual, the immigrant, the black man. It's the alcoholic, the smoker. And the fear of infection has driven much of what we think of as stigma as around TB. And here's what one woman told me a few years ago. TB, I can say that they've got that stigma. You see, because the most of them, they're telling themselves that TB, it's easy to infect. So this idea of contagion and infectiousness and wasting is often associated with stigmatizing experiences. But in the 21st century, at least in South Africa, we start to see that TB has become a marker, a sign for HIV. And rates of co-infection are so high that people automatically transfer the stigma of HIV to patients living with TB. For TB, they think the person with TB is with HIV and she's dying. We mustn't come close to her. They're pointing and pointing, and they're talking about that person. And then we have the peculiarity of extrapulmonary TB, which in some cases could mitigate some patients' experiences with stigma by removing the fear of transmission. If I'm coughing, they're just ignoring, looking like this. Maybe you're going to spit on them. Sometimes I say it's better because I'm not coughing since I'm working with people. In other cases, it could heighten stigma, particularly when it's accompanied by a visible trait or a symptom that could expose an underlying negative clinical attribute. If you've got lungs TB, I think it's better. Nobody knows what's going on. Glands TB, you're so ill and embarrassed because everybody knows what's going on. They think you've got HIV. And finally, we have now this fantastic XDR, or big TB, and by far this has invoked the greatest amount of stigma, discrimination, rejection compared to any other form of TB, and incredibly even HIV in many South African contexts. And we've seen this in the first quote that I shared today, and I think it comes across again right here. The landscape of TB stigma also appears to have been altered over the last decade. When I first started working in South Africa in 2005, TB patients, including those with MDR TB, would much rather prefer to share that they have TB compared to HIV. And we heard before that disclosure could be considered a proxy for stigma. Today, we have a scenario where patients would much rather have and disclose that they have HIV compared to TB. So in 2005, here's a quote from a man living with MDR TB and HIV. If you're asking a patient, what are you suffering from? The answer would probably be, I'm suffering from TB, but it's HIV that it is. And here's what a woman said to us a few years ago. It's better if they say I'm HIV than this XDR. I had that hope that I'm well, I'm alive, I don't have a problem, but this XDR came like when we first know about HIV. The final piece that we need to consider is the nonlinear health and social sort of consequences of stigma. Clearly, whether stigma is felt or enacted or experienced in a more tangible way, it results in some devaluation, some loss of status, some devaluation and sort of, exclusion. And people have written about this. I believe Miriam or Charlotte mentioned this. I mean, it reinforces social inequalities, negative clinical outcomes, delayed healthcare seeking, non-adherence to treatment, retention in care, a lack of retention in care, and non-disclosure, as we saw earlier. But is all stigma bad? Why are we measuring stigma? Are we assuming that stigma is a bad thing? And this is a bit of a devil's advocate question, I guess. Here's what one woman with extrapulmonary TB said: I want this thing to be finished, because everybody, if they're looking at you, I'm so embarrassed. People are looking at you, so that's what makes me not to forget to take the tablet. So stigma could be potentially a trigger for positive change. What an awful way to think about stigma, though. So at the end, I mean, what are the implications of this story, right? TB stigma is certainly a very complex social construct. It's dynamic, it's changing. Patients with TB often don't just have TB. They're often dealing with many other conditions that could compound or potentially replace the stigma that would be associated simply with TB. So with a scale, we may not be capturing the dynamic, multidimensional context of TB stigma. This is not to say that a scale shouldn't be produced and implemented, because I think it has a lot of value, as we've seen in the previous presentations. But I think we should be mindful of the limitations when we apply a scale and try to add more context in our analysis of a scale. So qualitative research, I think, can help improve the credibility. This is a term that we use to evaluate qualitative rigor of a stigma scale. We can do this through formative research by looking at what is the context in which stigma is sort of enacted in that local setting. This can allow us to sort of tailor and contextualize the stigma scale and enable a more nuanced understanding of a stigma score. And that's triangulation. And my final slide is about what do we do going from here. And I think when administering a scale, we could concurrently measure the broader determinants or indicators that help us to capture some of the social and structural sort of reasons underlying stigma. So not just collect data on whether, the patient, what race was he or she, what poverty level was he or she, did she have access to social support, but you really want to understand what's the role of the various other actors that come to play and produce stigma in this person. What does it mean to be a man or a woman in that context in which you're studying stigma? What are the roles and expectations? When we think about disclosure, we can identify yes or no, has this patient disclosed or has their willingness to disclose? But we want to think about what are the practices and norms of the health system in which that person is making that decision to you. Is contact tracing a norm? Well, if it is a norm and if there's a lot of awareness around contact tracing, disclosure may not be an option for an individual. That decision might be removed from his or her hands. So to think about these things and to collect data from various actors, which might be more tedious than administering a questionnaire to one patient, but to think about that when you assess the validity and the context of a stigma scale. If we're detaching TB stigma from other overlapping stigmas, we do want to understand and consider its utility and consequence. And it just goes back to the question, do we want to address TB stigma or do we want to address stigma in TB patients? I would also urge us, where possible, to repeat measurements over time, because stigma changes. People's perceptions and experience of stigma changes with their social location, as a colleague of mine, Jill Craig, says, or also in their treatment journey, during the symptomatic phase or during the continuation phase. And finally, to include some open-ended inquiry, because you just never know what you'll find, and it can be so very deeply interesting, even if somewhat unnerving. Thank you very much.
Thanks, Amrita, as always, not ready to reduce things to the oversimplistic. So we do have some time for questions. I know I have a few. I see Liz. Ernesto's going to take I think Liz was first, and then we'll move back.
Thanks very much. Well, just a comment, which is really great session. So, wonderful, and about time too, as we all know. Just to like a couple of observations. So coming from the world of HIV and TB, so HIV stigma is much more developed. I've just noticed a couple of differences that I think are important to bear in mind. First of all, HIV is a sexually transmitted disease, so people, even to be tested for a sexually transmitted disease, is not okay in many societies. We're not comfortable with that. But the testing step for TB is you're being tested for a respiratory transmitted infection, and I'm always amazed by how little stigma there is, even in societies like in Africa, where one anticipates that if you are found to be HIV positive, then you will be, TB positive, then you'll be assumed to be HIV positive. Nonetheless, there's no shame in being tested for TB. People will queue up in the street. My staff will put their TB specimens in under their own names. They certainly wouldn't do that for an HIV test. So I think the stigma kicks in at diagnosis. And what you do also see is a big difference by personal experience. So if a person has had a personal experience of TB, or they know someone who's had a personal experience of TB, which in Africa is about 50% in southern Africa, then their attitudes are very different. Again, reflecting, if you like, that fact that it kicks in a bit later than for HIV. So I would definitely include a question about that when you're looking to analyse. And that then where you see it most affecting, most interfering with public health is at the household contact tracing stage, where a patient has just been diagnosed with TB. They're getting this sudden experience of stigma, and we find that about 50% of patients actually don't want to have household contact tracing, even if it's offered. So you have to be a bit coercive to get them to do it. So again, I think that would be something that's useful and to think about. And then I had one other thought which I didn't write down, I've promptly forgotten. So thank you very much. Very, very good.
Who can first?
Hi, good afternoon. My name is Helena. I'm from TB Proof, and we're an advocacy organization from South Africa, and consisting of a large group of healthcare workers who developed occupational TB. And in this specific group, stigma is incredibly rife. Very few healthcare workers are willing to disclose that they developed TB, even if it's an occupational disease, and even worse if it's drug-resistant or XDR TB. So as organization, we've been trying to look at strategies to reduce stigma, to promote disclosure, and the one that we've been doing quite frequently is to tell stories. So to get healthcare workers who've had occupational TB to share their stories on a public platform. And I can promise you, after every single session that we've had in South Africa, we combine it with infection control training. There has been healthcare workers coming to us after this session saying, I've never told anyone this before, but I've had TB too. So that's our one approach. The second approach is a larger approach with the Unmask Stigma campaign, and this is an open invitation for anyone to collaborate with us. And we use a mask as both a symbol of stigma, but also a symbol of solidarity. So on World TB Day, we have a campaign where people can take part, tweet, and share photos of themselves wearing a mask, starting the conversation about TB and about stigma and how we can unite in a response. So anybody interested, please come and chat to us afterwards. A really important topic.
Can I just ask a question about that? So, because I've tried to understand the intervention there. So you wear it's called unmasked TB. And the mask symbolizes stigma, you said. So are you wanting people to wear more masks? Or are you wanting people to wear less masks? Or are you against the mask? If it symbolizes stigma,
So
because I can't figure out what the intervention is, what you want us to do. And similarly, have you evaluated it at all? Because Nina Summerland, who's sitting right there, is working on a systematic literature review on interventions to reduce TB stigma, and she also wanted to include it, but she couldn't figure out what you were doing.
Yeah, Great. So from our contact with patients and from speaking to healthcare workers, wearing a mask is a way to try to reduce the transmission of TB. So asking a patient who's coughing in a hospital to wear a mask is a form of preventing the spread. But patients and healthcare workers wear respirators. But both groups have come to us and said, I feel stigmatized when wearing the mask. It's sort of a symbol of my TB. I don't want to wear the mask. It has negative connotations. So with the Unmask Stigma campaign, we're saying let's make wearing a mask acceptable. Let's break down the stigma associated with this symbol. So if we all wear masks in the waiting room, when you're wearing a mask, you won't feel isolated and stigmatized. But it's also a powerful symbol of solidarity with TB patients, saying by wearing a mask, I'm standing in solidarity with you, wearing a mask to protect others, but also raising awareness about how important TB is.
So it's unmasked, but it means mask up.
Yeah.
And it is,
Yeah. So revealing the stigma associated with masks.
is it destigmatizing infection control?
We have only 5 minutes. It's going to be short.
Yeah.
Really, 1 minute.
I just want to say that the Unmasked Stigma campaign was launched by Mario Raviglione with the WHO. So we had a stakeholders meeting and it was cleared by the ethics committee. So we were asking specific questions about, isn't it more stigmatizing? And we had lots of discussions before we actually launched the campaign.
There were more questions coming? Yes.
Yes, good afternoon. I'm Merete Taksdal from LHL International, and I think that this symposium showed very clearly some difficulties in using qualitative phenomena into statistical data. And we are working with partners in different countries, among them Sudan. Sudan is a country where approximately 50% of the TB cases are even investigated, and there is high default rates, very low HIV prevalence though, and the stigma associated with TB is perceived to be extremely high. You have people being divorced as a result of TB, people having their houses burnt down, lots of tragic stories, and also because of the perception that TB is a deadly disease, people think that it doesn't really help seeking help anyway because they're going to die. So WHO conducted a stigma study that was a quantitative study. And then surprisingly to everybody working in civil society organization and patient-centered care, it revealed surprisingly low stigma rates. And then it proved that in order to carry out that investigation, they had trained quite a lot of university students as data collectors, dominantly male, traveling around, talking to people in waiting areas, filling in a 7-page tick-off form, which itself had so many weaknesses that I'm surprised that it resulted in a report that you can now find on the WHO websites. So just using this as an illustration that I think if we are supposed to have a TB-free world within 2030, each local community, each local country has to work on the phenomena in its own context and see what actions can be taken in order to improve the uptake of finding cases and treating them completely, reducing default, and so on. And also I have been to many workshops here on TB and migration. And for migrants, actually disclosing your status can be a reason for being deported or losing your job or whatever. So actually disclosure as a proxy in this context is not valuable for TB stigma because it is actually a realistic precaution to take that nobody else can know that you have TB. Thank you.
So that makes it an
I mean that
you
when you
can't-
use disclosure, willingness to disclosure as a proxy for TB stigma, in the case of migrants or also other subgroups, this might not be a correct proxy for stigma because they are actually losing their jobs if they disclose. It's not that they don't want to get care or anything like that.
Okay, but just to be clear, for us, losing your job is enacted stigma, or being deported is enacted stigma. That would absolutely be, if you didn't disclose because of that for us, that would mean stigma. That
Okay,
is
so-
discrimination is a form of stigma,
Okay.
the worst kind.
So that would be a very wide interpretation then of that proxy.
Thank you. Other questions, comments? Please.
I think one of our speakers mentioned it, but I think one of the things that would be very interesting to look into in more detail is a stigma around having latent TB. I mean, I've been at a number of sessions here where, particularly in Western Europe, we're looking at screening migrants. You're just talking about migrants and revealing whether they've got TB, or indeed revealing whether they've got latent TB. And I think that's another area. And I think if you've got latent TB, particularly if you're a contact of a family member, you don't want to reveal that either, because you're revealing that a family member is unwell and is on treatment. So I think the stigma around TB, I've already been telling Ellen, I did some work around this in East London, UK, about 15 years ago, but I think there's another interesting bit of work to do around latent TB as well.
Thank you.
Oh, got one more in the back?
I didn't get to introduce myself. I'm Andrea from TB Proof, and my husband is a healthcare worker, and he had TB last year. And my cousin is a healthcare worker, and he had TB 4 years ago. And my sister-in-law is Deline van Delft, and she had MDR TB 3 years ago. And as Elena Marie explained, we work a lot with healthcare workers. We're trying to change the attitude of healthcare workers and the language we use that we interact with patients, not just healthcare workers, but also researchers. And my colleague Pumeza, who's an XDR TB survivor, she has called repeatedly on the use of language that we use in interacting with our patients. So things like a defaulter, things like a TB case or a TB suspect. These are words that we use, but we are pushing away our patients that we are trying to get into our facilities. It's a small change that we can do, but it might mean the difference between life and death for a TB patient that needs to come in to be evaluated for TB.
Thank you very much. So I think we are getting really short of time, 1 extra minute. So Ellen, would you like to wrap up? Shall I? So I think this is exciting time. I mean, we have talked about this at the beginning, about the notion of zero suffering as part of the goals of the NTB strategy. But when we get into this field, we are now realizing that it's not that simple and easy to really determine the measurement that can guide investments. It does not necessarily have to stop us to continue doing the work and to, under the pillar 1 of patient-centered care, conduct the activities and strategize in more detail how to relieve the suffering and prevent and mitigate the stigma that is associated with the disease. There are a very powerful message from what Rita has said, which is not only the stigma associated with TB, but the stigmatizing condition in which the people with TB live independently of the condition. And this is something that we also have to consider when preparing and planning a proper response. WHO and the partnership and many other partners, including USAID, Charlotte, has been fundamental in really mobilizing the support and funding to get this process moving on. So we hope that next time when we convene the symposium to see the progress that the researchers are making in improving the body of evidence, we are going to have a bigger room, but more importantly, to continue counting on the civil society and the affected communities, because they are the ones who have to continue being the drivers of the response to TB, but especially in those neglected areas of work. So, and congratulations to Ellen, because she actually has been a major engine behind, and KNCB, Kitty is here with us. That means that the strong leadership of KNCB is behind this. These are the kind of orphan causes for many decades, and they cannot be any longer. Thank you very much for being with us today, and keep enjoying the meeting.